So shall I start?
Yeah. Go ahead.
Good morning to one and all. My paper today is Stitch in Time Saves 9 Lens-Induced Glaucoma in COVID Era. I have no financial interest. Coming to the introduction, lens-induced glaucoma is a secondary form of glaucoma in which the crystalline lens is involved in the mechanism of intraocular pressure rise, and often it is a marker of delayed cataract surgery. In India, cataract is the major cause of blindness in elderly population, and population expansion has only worsened our cataract backlog. 2020, early 2020 enters COVID, and with it enters COVID restrictions and cessation of elective surgery during the pandemic, which not only made, which further made eye care inaccessible to the general population. Aim of my study is to determine the clinical profile of lens-induced glaucoma, reasons of delayed presentation, and outcome of management of glaucoma in COVID era. The study place was Department of Ophthalmology, Vimsar, Bulla. It was a hospital-based prospective observation study. It was done in May 2020 to August 2021, and patients presenting to the ophthalmology OPD with LIG were included in the study with a sample size of 39. However, history of trauma, LIG due to subluxation and dislocation of lens, patients with history of cataract surgery or laser capsulotomy, known cases of glaucoma and vitreoretinal disorders, and other causes of complicated cataract were excluded. Travel and contact history was assessed in each case, and COVID-19 rapid antigen test was advised on suspicion. Informed consent was taken from each patient, and detailed history was taken. These were the study tools: and visual acuity, intersegment examination, gonioscopy, intraocular pressure, fundus examination, socio-economic status, demographic data, and reasons of delayed presentations were assessed. COVID-19 RT-PCR for each patient was advised before admission. Each patient underwent SICS, manual SICS, and 37 of whom received posterior chamber IOL, and 2 patients received scleral fixated IOL who had inadequate capsular support. Patients were followed up on day 1, 7, and 30, and best corrected visual acuity on last day of follow-up was graded as good, useful, and poor. My study had a female preponderance, and majority of patients hailed from rural background with a mean age of 64.1 and a standard deviation of 9.34 years. 16 patients were illiterate, and only 11 received secondary education and above. Socioeconomic status, according to BG Prasad scale, 21 were from lower middle class and 10 were from middle class. The common clinical symptoms were pain, photophobia, headache, and watering, and the most common clinical sign encountered were ciliary congestion, mid-dilated pupil, corneal edema, and 2 had even developed iris atrophy. The most common diagnosis was phacomorphic glaucoma. Visual acuity at presentation, 15 patients had hand movement positive, and the best visual acuity assessed was 1/60. Mean IOP at presentation was 46.28. The mean IOP, however, was assessed pre and post-op on day 1, 7, and 30, and the decrease in IOP was found to be statistically significant. Visual acuity at the last day of presentation was assessed according to the visual grade, and it was compared with the duration of symptoms found, and it was found to be statistically significant. As we have seen the plight of migrant workers, distance traveled by patients was also assessed and compared with the duration of symptoms, and it was found to be statistically significant. Patients who traveled more than 100 kilometers were usually late at presentation. Reasons of delayed presentation: patients were divided into COVID-related reasons and non-COVID-related reasons. COVID was a major determinant of late presentation, being COVID-19 lockdown and fear of COVID infection. Amongst non-COVID reasons, the most common causes were better vision in the fellow eye, financial problems, and no one to accompany them to hospital. Coming to the discussion, similar studies have been done by Setola et al. And Srishta et al. In Nepal, and a study by Ayob et al. In southern part of India. We found COVID-19 to be the major determinant in the late presentations, followed by better vision in the fellow eye, which was also seen by Ayob et al. Monetary problems were also a finding in our study, which was also found by Srishta et al., Sitola et al., Pradhan et al. However, our study had a smaller sample size, which is our limitation. Other studies had larger sample size, like 165 by Iobital, and Pradhan et al. Had 413. Coming to the conclusion, lens-induced glaucoma often precipitates in elderly population with long-standing and untreated cataract, and it can be prevented by early intervention with cataract. COVID-19 lockdown, fear of getting infected, good vision in the fellow eye, and lack of finances were the major determinant of late presentations in our study. Most patients were pseudophakic in the fellow eye, and there was a lack of awareness among patients about early treatment of cataract. And patients and general public should be educated about the risk of lens-induced glaucoma and its dreaded effect on vision. Early presentation with less duration of symptoms had better visual outcomes and as compared to who reported late. And indeed, a stitch in time in case of lens-induced glaucoma saves 9. These are my references. Thank you.
Thank you. It's nice presentation. Why female preponderance in LIC?
Sir,
This is a session of community and social ophthalmology.
yes, sir.
Answer in this background. Why
Yes, sir.
female?
Sir, often female are the neglected gender. Their complaints are often ignored in household. Even if they complain of low vision, it is often ignored. I think that's the reason they land up with lens-induced glaucoma. In our study, they have landed up more.
Have you seen that this incidence of cataract in Indian females are more compared to males? Have you
Sir,
noticed it?
yes, sir. In our normal OPD, in our setup, it is more we find female patients, and a male patient can come himself, but a female patient always needs an accompaniment with her. On asking about delayed presentation in female patients, they often complain that they had no one to accompany them to hospital.
Okay, thank you.
Thank you, sir.
First speaker is Dr. Rahul Mahala. Is he around? Dr. Rahul? I'm moving to next one. Dr. Santosh Agrawal. Dr. Santosh Agrawal, community-centered ROP screening approach. Dr. Santosh Agrawal is not around. Next is Dr. Subham Sethi. Welcome. Santosh is not here.
Hello, good morning everyone. Esteemed delegates, I am going to present my topic. The topic is Hook Tragedy, an incident of mass alcohol intoxication in eastern India. This is the abstract. Alcohol-induced optic neuropathy is a life-threatening condition. It results in long-term or irreversible visual impairment and cause blindness. The most common cause is adulterated alcohol, that is methyl alcohol, and it depends on individual metabolic predisposition. Early diagnosis and treatment is still a challenge. So the mechanism of toxicity of methyl alcohol. Methanol first gets converted to formaldehyde by alcohol dehydrogenase, which is oxidized to formic acid. And the formic acid attacks on mitochondrial cytochrome C oxidase, which degenerate retina and optic nerve. So in our study, there were 20 male patients of age group 20 to 40 years presented to our hospital with blurring of vision. The range is 660 to no PL after intake of adulterated alcohol. And all the patients were examined by visual acuity, slit lamp examination, IOP measurement, fundoscopy, VEP, and OCT. So in total of 20 patients, 10 patients are within the range of the visual acuity 660 to 4/60, and 6 patients are having 3/60 to 1/60 vision, and 4 patients presented with CFCR to no PL. In fundoscopic finding, we found 12 patients having peripapillary edema, 4 patients having hyperemia of optic disc and venous engorgement, and 4 patients already started developing pallor of the optic disc. In slit lamp examination, 2 patients where there is no RAPD, 9 patients having grade 1 RAPD, 7 patients having grade 2 RAPD, and grade 4 RAPD in 2 patients. In VEP, we found 4 patients having normal VEP, 8 patients having prolonged latency period in the VEP, and no wave formation there was in 8 patients. In OCT, 10 patients having normal OCT, thinning of neuroretinal rim found in 8%, and 4% showed foveal flattening. Perimetry we have done in only in 12 cases because of poor visual acuity. We could not perform the perimetry examination in all 20%. We found central scotoma in 9%, altitudinal field defect in 2%, and centrocecal scotoma in 1%. So the management part, how we manage the patient? First, IV infusion 7.5%, sodium bicarbonate, loading dose of 180 milliequivalent, maintenance dose is 180 milliequivalent per hour, 2% absolute alcohol in dextrose with a loading dose of 0.6 gram per kg body weight, IV methylprednisolone, hemodialysis, injection methylcobalamin, and antioxidant. So we followed the patient for 3 months. So 14%, that is 70% of patient improved to 624 to 660. 4% improved to 636 to 660, but later deteriorated to 360 to CFCR, and 2% did not improve at all. So coming to the discussion part, toxic optic neuropathy is a reversible phenomenon. Formic acid accumulation in tissue causes metabolic acidosis and ocular toxicity. Visual loss is dependent on initial dose of methanol ingested and interval between ingestion and start of therapy. Significant association between the risk of thinning of RNFL and value of arterial pH measured at presentation. Pupil reactivity in the initial examination may provide important prognostic information for further visual outcome. Antioxidant and neuroprotective agent got significant role in toxic neuropathy in alcohol poisoning. So the conclusion part is methanol poisoning is a health associated disorder. pH is the best predictor for final visual outcome. Early diagnosis and prompt treatment is most important. Awareness in society is paramount, and proper documentation should be done in all alcohol poisoning cases. These are my references. Thank you.
Though it is looking funny, are you actively involved in this study?
Sir?
Are you actively involved in this study?
Yes, sir. Yes, sir.
Very funny question I am asking. Which brand of alcohol the patient consumed?
So the adulterated alcohol,
There must be a name for
no,
that.
sir, desi alcohol, they make it, the hook, that means they prepare it, the common people, they prepared it. The labor people, low socioeconomic people.
Okay,
local
made
local
alcohol.
made, sir.
Okay, fine.
Sir?
When patient presented to you?
Sir, patient presented to the first.
Usually it is a social stigma. Patient came to us very late, on 7th day or 10th day, like our 5th day.
Yes, sir.
Not
First, the
to-
patients
no-
were admitted to the hospital,
General
in
hospital.
medicine ward. From medicine, they gave us call and we examined the patient.
What was the time period of that?
Sir, within the 7 to 10 days.
Time period from which month to which month?
Sir, it was done in 2019 April. Yes, sir.
Before COVID.
Yes, sir. Yes, sir. Before COVID.
Before COVID. Is there any role
At
of
the election
steroid?
time.
Is there any role of steroid, bolus steroid?
Yes, sir. Yes, sir. Sir, steroid decrease the inflammation. Yes, sir. In the optic neuritis, first we give the steroid.
Okay, fine. Thank you. Sir, next.
Sir, 20%, sir.
Next, have you went to the spot? Dr.
Yes.
Jyotsna
No, sir. No, sir.
Sharma?
In this regard, I just like to recapitulate in the year 2012, I had got a very bad experience and rare opportunity to go to the on-spot of good tragedy in West Bengal, in Darmodhar area, where I have seen on my own eyes 147 who have taken huge adulterated
Sir, this hooch is the name of that brand?
No,
It
sir.
was called as Haku, which is an English of this particular alcohol is Huch line is in English literature you can see Huch.
That hooch.
Yes, but in those areas it is called Haku, Haku, Haku. They used to get Haku. But all the laboratory take with this organophosphorus compound just to get an accelerated action. They pinch up. But if the dose is high, this organophosphorus, then it will be poison. Otherwise, it's excellent.
So it's organophosphorus which is the cause for death in these patients?
Yes.
It is not, no, it is not the hooch,
Due to organophosphorus.
not, not due to alcohol.
Methyl alcohol. No methyl alcohol was there.
Okay,
Methyl alcohol, that was an
okay.
Any patient died in your study now?
No, sir. No, sir.
Next.
Your name is Susut and Pandit Bharat.
Sir, it's Sushrut Anand. Some father's name is added actually. So महाराष्ट्र में पढ़े थे तो साथ में जुड़ा हुआ है.
Welcome, man.
Thank you, sir. Good morning, everybody, and the delegate dignitaries on the dais. First of all, I would like to.
First time I'm listening this kind of topic, recycling of contact lens and all.
Actually, this was a question raised by my patient, and that led to this thing, sir. Actually.
No, this is first time I'm listening.
Yeah,
Recycling.
so this is, I think,
New thing.
definitely is the first time. First, I would like to thank AIOS for giving me this opportunity. Today, I will be presenting on something like that, building responsible organizations, recycling of contact lenses, actually. So nobody thinks about recycling of these lenses and the plastic load that these type of lenses gives to the community, actually. So introduction. Social responsibility is a very important to us as hospital, and helping to protect our environment is a part of that. For years, contact lens wearers have struggled to find ways in which to dispose the lenses ethically without resorting to sending them to landfill. Reducing plastic waste is high on agenda, and we are really pleased to know that we are working on proper method to recycle contact lenses. Being the owner of Ananda and Eye Mother Care, I'm happy to protect the environment by researching on contact lens recycling scheme, as it will bring down into practice method to divert the waste from landfill sites. What we need to know is that even if we make the effort to recycle contact lenses and packaging in standard recycling bins, they can get wilted or due to their small size, contributing to landfill waste across the country. Contact lenses in India. Contact lenses continue to register strong value growth since 2016. That was due to the rising popularity of these products among urban consumers. The increasing availability of the contact lenses in Indian market is due to the growth branded retail outlets and online retailing. The estimated lenses used in India is around 40 lakhs. And each of the lens weighs around 3 grams. So coming to the total plastic that we are giving to the community is around 12,000 kilograms of plastic annually. The problem statement is, the used contact lenses are prevalent in wastewater sludge after sewage treatment. The problem is that since sludge is often deposited on land, these lenses can eventually wash into lakes or rivers where fishes, birds, and other animals can consume them. We cannot ask people to stop wearing contact lenses, so many people depend on them. Daily disposable ones, and rather the ones we wear for a week or more than that, is a fast-growing part of contact lens market and are more convenient and safe. So it is better since we cannot stop the people, it is better to encourage people to dispose of these lenses properly. Bosch & Lomb has partnered with with a company called TerraCycle, which specializes in recycling small items and wouldn't normally get separated by the standard process. Bosch & Lomb actually is doing this in US and Australia, sir. And researchers have found that this company is seriously pursuing contact lens recycling program. Thus, in India, we also need to get started such recycling methods. Disposing lenses into waste containers, sinks, and toilets can create plastic waste as they are made of such tough plastics which do not break down fully when exposed to microbes. A little about the chemistry of the contact lenses. Soft contact lenses are made up of generally hydrogen containing water content of 40% to 50 to 60%. And vision correction is a chronic need everywhere. More and more people are turning to contact lenses per year. And since 1991, the number of contact lens wearers has increased by 4% every year. People's reason to wear contact lenses instead of glasses range from active life cycle choices to cosmetic reasons. This is the chemistry of the contact lenses. What is the environmental effect on flushing contact lenses? Every year, Indians flush over millions of contact lenses down the drain. Researchers have found that the lenses did not effectively break down in lab simulations of water treatment facilities. Around half of the treated wastewater and whatever else in it ends up getting dumped into the soil after treatment, meaning anywhere around 11,000 to 12,600, 500 kilograms of contact lens fragments end up in the country diet annually. Contact lens fragments could impact the soil, potentially shattering into small pieces, where those microplastics could enter into the food chain. Lenses are absorbent, taking into toxins and surrounding dirt. Also, how many end up in oceans and waterways couldn't be determined, thus entering into fishes and other animals, which can be very, very hazardous and dangerous to their lives. Life cycle of contact lenses. The main raw material of all contact lenses is plastic polymer. Different plastic polymers depending on the types. Hard contact lenses are made up of PMMA, and the soft ones are made of polyhydromethyl acrylate. These plastic polymers are also called as hydrogels or silicon hydrogels, depending upon their types. The process of making is, there are two processes involved. One is molding and the other is lathing. This is the molding process. In step one, the raw material of the contact lens are injected. This I should skip actually. Coming to the execution of the plan. Actually, I started this study. This was the one question asked by one of my patients, that how should we dispose of the contact lenses. So this led me to think about definitely there need to have process that we can properly dispose of the contact lenses. Unluckily, it was started just before the COVID, and since the uses of contact lenses reduced drastically in COVID, so I don't have exact data, but even if we take an assumption of disposing around 20 lenses, we can reduce 60 grams from a center coming into the environment. The execution in collaboration of the silk lens and TerraCycle, how it should be executed. Patients purchasing contact lenses are consulted regarding hazards and improper disposal of about benefits of recycling of lenses. Their addresses and full detail are recorded and written during duration of this is given. Different sizes of recycled boxes are shown to them. During disposal of lenses, they are asked to use these boxes and then shipped to our hospital. This is the protocol that we made. How it works. Yeah, so coming to the conclusion, social responsibility is very important to us as a company, and helping to protect our environment is a part of that. For years, contact lens wearers have struggled to find ways in which to dispose the lenses ethically without resorting to send them to landfill. Reducing plastic waste is high on demand agenda, and we are really happy to scheme out that gets implemented. There's a real focus on reducing the amount of plastic that is polluting our planet. As this would be the first scheme in India to be launched, it is bound to have an impact on the amount and the contact lens waste recycle. These are the references. Thank you, sir.
So what's your take-home message?
Sir, my take-on message that we should definitely implement this because what a single person uses, that is very small in amount and the weight, but the overall load that we get of plastics and the amount of plastic that is being the studies going on plastic, that we should reduce the uses of plastics. This is a huge weight load that is being given to the earth because of the use of contact lenses. So we should definitely go for this proper way of disposing these lenses, sir. Thank you.
So from this session, sir, only 3 are there. And we had Dr. Dipti Prabha Eka. Yeah. Clinical profile of ocular trauma in tertiary hospital of Central India.
Good morning, all. I'm Dr. Snehal Marik, and I'm presenting my work on clinical and epidemiological profile of ocular trauma in tertiary hospital of Central India. Simple yet important topic. Ocular trauma is a significant public health problem, particularly in developing country like India. Uh, it is it is important cause of monocular visual impairment and blindness. The late presentation may lead to increased morbidity and complication rates. The epidemiology of ocular trauma varies from place to place, which in turn depends upon the workplace traffic states of that area. So health education safety strategy should be addressed separately for each region. Thus, we aim to highlight clinical profile risk factors and prevalence of ocular trauma in patients attending to OPD of Uchan Charitable Trust Hospital, a tertiary hospital of Central India. This is a prospective observational hospital-based study done for a period of 1 year. After taking permission from ethical committee, we've selected a cohort of 156 patients. A written informed consent was taken, detailed history was taken, thorough ophthalmological examination and radiological investigation was done, and data was analyzed. Coming to the result, out of total patients, 156 patients were obtained, so the prevalence rate was 5.8%. Most of the patient was male, so the predominant patients were male, accounting for 84.6%. Most of the patients were from rural region, accounting for 93 out of 153 patients. The age pattern, the most common age group was 16 to 45 years of age, accounting for 80% of ages. The most common mode of ocular trauma was agricultural, followed by industrial and road traffic accident. In our finding, we found the lid involvement and conjunctival involvement were seen in almost all patients, but corneal aberrations, corneal sclera, tears, foreign body over cornea, hyphema, and iris prolapse were the most common findings observed. These are the few patients. Out of 156 patients, 126 patients required surgical interventions, while others were treated medically. Coming to the discussion part, our study shows a prevalence rate of 5.8%, which is in accordance with Arvind Comprehensive Eye Studies, while other studies like Andhra Pradesh study shows higher and Rajendra Prasad Maurya study shows lower incidence. This is an established fact that male has more incidence than female, and which this study corroborates the same. The most common age group is being 16 to 45 years. This is the young, active, working age group, which drives the economy of the society. And our study consistent with Charlie's and Dharma, while a study done by LMKD shows pediatric prevalence. So the most common cause observed was agricultural. This pattern may be because most of the patients from our places were from rural region, while Gully and others found that the most common cause was road traffic accident, and Rajendra Prasad Maurya found work and home as being most common cause. In our study, most common findings were lid dilatation, corneal aberrations, foreign body over cornea, and iris prolapse, and hyphema. And cornea was the most commonly found structure, which is consistent with other studies as well. We have 126 patients who required minor or major surgical interventions, but Kinde et al. Shows 53 patients patients showed ocular surgery, while Maurya et al. Found most of the patients required medical treatment. Coming to the limitations, we found that to study the epidemiology of this particular ocular trauma, the sample size should be more. Since we have considered only physical ocular injuries, chemical ocular injuries are not involved in this study. So concluding, males are more predominant. Most of the population were rural based. The most common cause was agricultural. After eyelid involvement, cornea was the most common cause. So so as a good visual acuity is associated with early intervention, emphasis must be given on public awareness, health education, and strict legislation to use personal protective measures like goggles during work to reduce the occurrence of ocular trauma. These are the references. Thank you.
Thank you.
Thank you, sir.
Any questions, sir? Sir, Samantha sir, any?
Yes. So, commonest one in your injury? What
So
you
they
have
were,
observed in your clinic?
so they were male predominance were there.
Injury of the particular portion of the eye.
So cornea was the most commonest injury we've
How
observed.
much of them were blinding injuries?
So blind, one patient was there, sir.
Amongst
Among 156 patients,
156,
one patient was blind. Yes, sir.
what was the cause of blindness?
So he had retinal detachment, sir.
Then it doesn't.
Yeah, so actually it was an so
No
this is
endophthalmitis, no panophthalmitis.
no sir, no sir, no sir. Since it was 1 year period of time, we didn't found it. Though we found it, we've observed it, but in our study,
Amongst those 156,
yes sir,
only one patient went blind due to retinal detachment.
yes sir,
Am I okay?
yes sir. That was due, or that was a old.
That was old patient. But amongst your cohort of 156, nobody
No,
went
no, no,
blind.
no, sir, no, sir, no, sir, no, sir. We have not observed a single patient.
And everybody has got good working vision.
Not working, sir. Few patients with corneal opacities or few patients with dislocated lens.
Not at all blind.
No, no, sir. They were not blind. They had PL positive or finger counting vision.
Then question arises, what is the definition of blindness?
So, yes,
Do
sir.
you think it is?
Windows say,
You say only PL is there. Is
sir,
PL is- what is social blindness?
social blindness is less than. Yes, sir.
Social blindness.
Yes, sir. They, clinically they were not, but social blindness, yes, definitely they were social blind.
So how much percentage of them were socially blind? As per our Indian community session.
Yes, sir.
That you are answering a giant of this.
Yes. I'll definitely take care, sir.
So you must know,
Yes, sir.
you must know,
Yes,
there are three types of blindness. One
Social.
medical blindness, one social blindness, one medical legal blindness.
Yes, sir.
So, in our day-to-day life, we have to know how much percentage of the people are socially blind.
Socially blind. Yes, sir. Definitely I'll take it. So I'll,
Permutation, combination, data collection, से तो काम नहीं हो पाता.
yes, sir. I'll definitely take care of it, sir. Yes, sir. It is 3/60. So I was talking about medical. Thank you. Thank you.
Running by 6 by 6 after cataract surgery, man.
Yes.
Nobody is thinking of this. Next day, sir. Next day, very next day, 6 by 6, unaided. Unaided. This is where we are lacking in community services. Thank you. It's nice paper. See, you are going to present the same paper.
Yes, sir. Yes.
Okay.
Dipti.
Sir, marking. Yes. Can we help you? And those three papers you are not. Yes, yes, yes.
दीप्ति फर्स्ट सेशन में था इससे पहले हाँ या अभी टाइमर सेट कीजिए shall I start yes sir shall I start
Yeah, sure. Your time
Good
is
morning,
up.
everyone. I'm Dr. Dipti, and I'm going to speak on does high heat environment is responsible for cataract and epidemiological investigation in blast furnace workers. I have no financial interest. The relationship between heat and cataract was first studied by Hister and Winzel and in as early as 1739 in glassblowers, which was also known as a glassblower's cataract. By 1929, heat cataract came to be recognized as an industrial disease, but surprisingly, not adequate studies has been done. India being an industrial giant, there are large number of industries like the steel industry, the glass industry, the aluminum and the cocoa oven plants where thousands of workers are exposed to high heat on a daily basis. The current study was conducted among workers of blast furnace in one of the largest steel plants of India, where approximately 700 workers are posted and work in extremely high temperature, about 1200 to 1500 degrees Celsius. The aim of my study was to investigate whether occupational exposure to heat is responsible to cataract. It was an observational cross-sectional study. Timeline was from Jan 2021 to March 2022. We took we took two groups. One were cases were from workers of blast furnace. Controls were from non-heat exposed regions like marketing, personal and finance. Both groups were age matched and informed consent was taken. Age group 30 to 50 years were included. Persons with previous history of ocular trauma, surgery, diabetes mellitus, steroid use were excluded. A detailed questionnaire regarding lifestyle, occupational, medical and ocular histories were taken. A comprehensive ophthalmic examination including fundus, OCT and applanation was done. Cataract was defined as lens opacity greater than 5% of lens surface on retroillumination. We got 92 cases and 92 controls. Since company's policies debars women from furnace areas, so all our cases were male, and to prevent gender bias, we took also controls were also males. The mean age of cataract in cases was 46 plus minus 5.2 years. Mean age of cataract in controls was 48.5 years, with standard deviation was 6.8 years. In controls, the lenticular opacity was 38.4%. In cases, the lens opacity was 54.34%. The odds ratio was 1.9, which means that almost twice the odds of getting cataract if one is posted in the furnace. Nuclear sclerosis was the predominant cataract, followed by PSC, true exfoliation, and also alarmingly there were 12 cases of mature cataract and 5 of them were not even aware of the cataract. When we analyze the duration of posting in the furnace with the number of persons having the cataract, after 10 years of exposure, there was steep increase in the persons having the cataract. The Pearson correlation coefficient was 0.9, which shows a positive correlation. These are some of my photographs of the cases. Coming to the pathology, the exact pathology of heat cataract is a highly debated issue. In Pick's lens, it is found that under the influence of heat, the alpha crystalline protein of the lens, it undergoes a loss of its native conformation, leading to partial unfolding, ultimately leading to cataract. So summarizing, the key points of my study was that compared to their non-heat exposed counterparts, blast furnace workers had greater prevalence of cataract, earlier age of onset and positive correlation with duration of exposure. Our study findings were similar to the Sweden industry, iron and steel industry, who had shown the risk to increase to 2.5 times. In Wales, their heat exposed workers had 63% of lenticular opacity compared to 48% in non-heat exposed workers. Similarly, Bangladesh rolling mill workers have 15% of lenticular opacity. Swedish study also had exfoliation cases. The main limitation of the study was that when we visited the plant, these workers are also exposed to infrared radiation, which can serve as a possible confounding factor. This study would have been stronger if we could have quantified the exposure dose so that dose-effect relationship could be established. So take-home message will be the ocular health and productivity of labor are highly correlated. In order to recognize thermal cataract as an occupational hazard, the first point is one should be aware, both management and workers, and guidelines should be formulated. Regular eye examination should not be just an option, it should be a mandatory for each and everyone who is posted in the furnace. And just like in plant, the safety shoes and safety helmet is compulsory, and without that one cannot enter the plants. Each and every furnace worker should be provided not just with regular safety goggles, but goggles with thermal shield. Then, last and not the least, more studies should be made in India by rummaging the literature. Not a single study has been found in India. Thank you.
Thank you. Excellent. Dr. Rekha, have you heard the term nutritional cataract?
Sorry, sir?
Nutritional cataract?
Yes, sir, I've heard it.
What is the difference between this glass blower cataract and nutritional cataract? Because these laborers who are working in front of furnace
Yes, yes.
are of low socio-middle class.
Sir, I would differ. This study, it was irrespective of the socio-economic study. The first, actually the idea of getting the study was one of my husband's friend. He's an executive and he's just 35 years old and he had that cataract. So that got me into thinking. It is not that the non-executives or the low socio-economic persons were getting the cataract. Even the high-class executives were getting in 50s, in the early 45 years. We had one of our general manager who was 45 years old and he had the cataract. And when compared to his counterpart who was in the finance department, so this was the age matched. I
Confused.
Yes. No, sir. Whenever there is a breakdown in the steel plant, even the GM has to also go and work for, in order to, even the high class engineer, he has to also get exposed to that. No. But still, then, sir, that is why one of my limitation was that I could not quantify the amount of exposure. But exposure is there. Yes, sir, I have told in my limitation, that was the limitation. One I cannot quantify. But the exposure is even for the GM and even for the non-ex worker.
Why nuclear sclerosis is more in your study?
Sir, some studies in the student study,
That was actually the direct question for you.
yes, in the literature it has been, one of the theories is that the heat get concentrated in the posterior capsule, and for that it is just a theory. The exact pathogenesis still we don't know.
So heat get concentrated in the
Posterior capsule. Even Wenzel, when he did the study, he had told the exact theory in 1739. Get in there.
Why is nuclear sclerosis?
Guess then posterior. Sir, in the posterior capsule, then it get concentrated in the nucleus. But exactly why in the nucleus, that we don't know. And moreover, it was not very significant type of category.
Why I am asking, we are working in northern part of India, and we had lot of cataract patient, and in my clinical practice, 70% of my patients are female patients.
Yes,
And
yes.
that too, their mean age is less than 50. That's why what I am saying, and I am concluding, that these ladies are still the second class citizen of our society. They used to have skip their breakfast, they used to have skip their dinner.
Yeah.
They have micronutrient deficiency. That's why they are getting this kind of sclerotic cataract in early age compared to Western literature. This is my presumption. I may be wrong,
Yeah,
but
no.
certainly nutrition has some definitive good role to prevent pre-senile cataract.
Yes. So nutritional cataract is definitely one of the cause.
Congratulations.
Especially in the meetings of holding
Uh,
midterm conference in Eastern India, and your presentation
what is next session here?
on this particular zone of Bengal, where we have got so many minds.
Next session.
Anybody more?
Sir, anybody for this session? 3 names left, sir. कौन से लोग नहीं हैं, sir? किनका है? ये चल रहा है ना? इसके बाद कुछ है? वो लोग आ गए हैं. Dr. Salav, the next session is diabetic retinopathy and medical retina. Sir. Dr. Shah, I want, sir, let us see the contact lens disposal. Can you skip?
We have to take a group photograph.
Just sir, 2 method ही बताया था ना, contact lens disposal का.
Sir, you had asked about the lathing and that molding process. Actually, this is the process of making the contact lenses, and how they are being made. Actually, that is the process of lathing and the molding. Sir, raw material, first of all, raw material collect karke, then we go for getting that raw material into the molds, and the lenses are heated and made into the solid form.